Good afternoon, everyone, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared towards long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today, we'll be discussing schizophrenia diagnosis and CMS coding audits. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be kicking off a month-long series called Getting Ready for the MDS 3.0 Changes. If you would like more information about this series, I will drop a link in the chat shortly with further details. And now I'd like to introduce our guest today, Tammy Coleman. Tammy is the Vice President of Clinical Reimbursement for Affinity Health Services, with 25 years of long-term care experience. Tammy has worked as a nursing supervisor, assistant director of nursing, and director of nursing prior to joining Affinity Health Services, Inc. She has experience with development and implementation of quality assurance initiatives focused on improving residents' quality of care and life in the long-term care environment. And she has achieved a certificate of training in infection prevention in the long-term care setting. Tammy is certified in Quality Assurance and Performance Improvement Program, also known as QAPI, and she is a certified Interact champion and a certified director of nursing for long-term care. Tammy also has advanced training in patient-driven payment model, or PDMP, and provides the leadership for the registered nurse assessment coordinators in her organization, and is an advanced certified resident assessment coordinator, or RAC-CT. Tammy, thank you for joining us today.
Thank you. I'm going to go ahead and get started. We're going to talk today about schizophrenia, the MDS coding of schizophrenia specific to I-6000, and then also the CMS audits that CMS had put out the memo for earlier this year. So as previously stated, I am Tammy Coleman. My email will be shared with you. So if you have any questions, you can certainly, reach out at any time. So first we have to talk about everything that happened that led up to why there's now this I-6000 CMS audit. So the Office of Inspector General did some reviews of schizophrenia, and they found that from 2015 to 2019, the number of long-stay residents that were coded in I-6000 with schizophrenia had actually jumped 35%. This is, reported from, on the MDSs, and basically what they're saying is there's lack of that diagnosis in those Medicare claims prior to the nursing home admission. They're stating that, the reported assessments for these long-stay residents are ages 65 and older, and the audit itself was done between 2011, 2019. So basically, there's been a significant increase in the number of residents with no indications of mental health or any clinician care based on from the bills for a diagnosis of schizophrenia prior to them being admitted to the nursing home. So the increased schizophrenia diagnosis coincides with the addition in 2015 for the long stay quality measure for the percentage of long stay residents receiving antipsychotic medications. The schizophrenia diagnosis itself actually excludes you from being pulled into that quality measure. There's other diagnoses that can also exclude you, Tourette's and Huntington's, but the schizophrenia seems to be the one that has had that significant increase. So, more than 3/4 of the residents with MDS reported schizophrenia had no related encounters from the claims saying that they were treated by a qualified clinician for that psychiatric diagnosis. So the bottom line basically is that more long-stay residents are being coded with schizophrenia in I-6000. More long-stay residents have schizophrenia diagnosis as coded, but didn't receive the managed care for that schizophrenia based on the claims that were submitted to CMS from the clinicians. And greater than 75% of the residents who did meet those first two, were excluded from the quality measure based on having a diagnosis, right? So they were receiving the antipsychotic medication. They didn't have the practitioner, that clinician follow up, but they had that diagnosis that then excluded them from being counted in the measure. So lots of things then took place, right? So CMS had to obviously respond to this OIG report. And so a lot of different things happened then. In 2022, in the summer of 2022, there was updated guidance put into the REI manual for how the RNACs are supposed to actually code I-6000, right? In October, the CMS, our state operation manual, Appendix PP, was then updated, indicating how we're supposed to, collect this information, how we're supposed to assess this information, and what we need to have in place from the practitioner standpoint. And then CMS also updated their critical element pathway in regards to how the Department of Health is supposed to look at this when they come in to our facilities for the regulatory compliance piece. And then we had that release of the QSO 2305, where they talked about the updated nursing home compare website, and they were adjusting quality measures based on errorist schizophrenia coding. So the first thing we have to talk about is that active diagnosis piece, right? Because everything comes down to when we're capturing something on an MDS, the RNACs have to look for two different pieces, right? They have to ensure that the physician has documented that this is an active diagnosis. That documentation has to happen within 60 days of the time that they're doing the MDS. The other thing that they have to look for is, do we have active treatment, right? Do we have active treatment in that 7-day window? So the ARD, or the assessment end date, and those 6 days prior. And if both of those occurred, we were always supposed to capture the diagnosis. The physician said they had it, and we were actively treating it, right? But now, based on the two pieces that we talked about in regards to the update to the REI manual, and then also the update to the Appendix PP, there's been guidance that basically says that, in situations where the practitioners have potentially misdiagnosed the resident with a condition for which there is lack of appropriate diagnostic information in the medical record, such as the mental disorder, the corresponding diagnosis for Section I should not be coded. So basically in the guidance, they're now stating that not only do we have to have the diagnosis from the physician, we have to have the active treatment, but we also have to meet the requirements for the appropriate diagnostic information. Like, all of those pieces have to be present. And then it goes on to say that, in those situations where there could have been potential misdiagnosing, the surveyors are supposed to consider referring the facility and or, the medical director to the medical board and the board of nursing. So, they're two of the key pieces, and that's kind of written in all of the language, right? So it's now, it's in the RAI manual, it's in the regulations, it's on the critical element pathway, and it's also, in that QSO over and over and over again, that we have to have all of these pieces. So, let's talk specifically about that active diagnosis piece, right? So in the REI manual, that this was an update that went into effect July 15th of 2022. This is where they basically said very clearly, in those situations and conditions, we are not to capture that diagnosis if we don't have the supporting diagnostic information. So in the examples inside the REI manual, the example that they give is a resident was admitted without a diagnosis of schizophrenia. After admission, the resident is prescribed an antipsychotic medication for schizophrenia by the primary care physician. However, the resident's medical record includes no documentation of a detailed evaluation by the appropriate practitioner of the resident's mental, physical, psychosocial, and functional status, and persistent behaviors of 6 months prior to the start of the antipsychotic medication they weren't present, which is in accordance with the professional standards. So it says that we would not code schizophrenia in I-6000 because it says, although the resident had a physician diagnosis for schizophrenia, is receiving an antipsychotic medication, the coding of schizophrenia diagnosis would not be appropriate because there's lack of documentation of a detailed evaluation in accordance with professional standards. The resident's mental, physical, psychosocial, and functional status and the persistent behaviors were not there for that required time frame. And when we're talking about the schizophrenia, and the use of those medications, they're saying that they're supposed to have those behaviors for at least 6 months. And we have to have documented evidence of that. So they went on to say that, the questions were, should the MDS coordinators modify the assessments? So in that July of 2022 error that was put out, they said that the RNACs don't have to go back and audit I-6000 for, the previous coding. But as they're moving forward, if they identify that something was not coded correctly, we do not have all those pieces, we are supposed to correct it. So we are not supposed to capture it. So that was one of the big pieces that happened last July, right? And then we know in January, CMS put out the QSO. That QSO was 2305, and that came out January 18th. And, in this QSO, they basically, notified us that they were going to start auditing facilities because they felt that there was erroneous coding of the schizophrenia diagnosis. And they did tell us that, if they identified from that audit that there was erroneous coding, then there would be consequences to the facility, right? Their quality measures would be downgraded by a couple of different pieces. They are going to, address the long stay quality measure for the antipsychotics, but also the short stay. So there's a couple of different pieces that were there. And basically that QSO said CMS is concerned that, some nursing homes have erroneously coded residents as having schizophrenia, which masks the facility's true rate of antipsychotic medication use. Therefore, CMS is going to be conducting off-site audits for schizophrenia coding. And based upon those results, they're going to adjust that star rating. And what they're going to adjust there is, it's pretty substantial. So we're going to talk about that. They went into saying that they had already done a focused survey in 2016 that looked at the schizophrenia diagnosis. The survey basically identified that there were patterns of erroneous coding for residents with the schizophrenia. They stated that the offsite audit did reflect that the MDSs were not correct based on the fact that we didn't have all of the pieces that were needed. So they, decided that they were going to start auditing, especially those buildings that had probably very low, right? A pretty low quality measure. They were doing pretty well because their percentages were low, or if they had a drastic change, right? So they did say one of the examples, like they gave examples of some of the erroneous coding. There was an absence of a comprehensive psychiatric evaluation and behavior documentation. They also said many residents had only one sporadic behavior noted in their medical record, and the behaviors were related to dementia and not schizophrenia. So like their real focus is, not just on having that medical evaluation, but what are the behaviors? Do those behaviors actually meet the clinical manifestations for signs and symptoms of schizophrenia? And how long did that behavior persist for, right? Is this something that they had one bad day or one bad weekend? Or did they have this for the 6 months that really is supposed to be there before we start them on this type of medication? And then the other piece of that was there was no targeted behavior, or there was no targeted behavior documentation, right? We weren't monitoring that behavior, and we weren't monitoring for the side effects. So they're going to conduct the audits, right? And they're going to adjust the quality measure scoring if they find that there was erroneous documentation. So how is this all supposed to work? They're going to send us a letter, right? The letter is going to come out and they're going to basically tell us that they're going to do an audit on our building, right? And if they find erroneous documentation, then there are things that are going to happen to our quality measures. So the biggest piece is our overall quality measure for long stay is going to be downgraded to a 1-star for 6 months. So downgrading that quality measure to a 1-star automatically takes a star from your overall, right? So if your overall star rating was a 3, if your quality measures get downgraded to a 1, your overall star rating is now a 2, right? Because the minute your quality measures drop to a 1, you lose an overall star. They're also going to suppress that short stay quality measure for 6 months, right? And then they're going to continue to suppress your long stay quality measure for 12 months. So you're going to have a difficult time having a decent quality measure star rating because of the suppressions that they're going to do. And then they're going to continue to audit. If they find that there was errorous documentation, if they decide that this is what has to happen for your building, they were very clear that they're going to continue to audit to make sure that not only did you correct it, but you keep it corrected. And then they did say that, you know, facilities do have the opportunity to forego the audit. We can actually say, you know, I want to forego the audit. I feel that something was not done right. And then it does say that, you know, CMS has the right to consider a lesser action, you know, in relation to what will happen to your star rating. It doesn't say that they will do it. It just says they can consider doing something lesser to you if you forego the audit and basically say, we know that there was errorous documentation. So, you know, we have to talk about the fact that, again, they said they're going to continue to monitor, right? And that follow-up action, you know, they can continue to suppress if they feel that we did not only correct it the way we should have, but didn't keep that correct. So very clear that, you know, they can continue to suppress us until we actually have this issue corrected. So let's talk a little bit about what that CMS letter looks like. You know, we're going to get a letter. It's going to come certified. It's going to be addressed to the administrator. The subject from CMS is going to be the schizophrenia minimum data set audit. It's going to, well, the audit contractors are Myers and Stauffer. And they're basically going to, in the description, tell you that they are now conducting an audit for your building for the accuracy of the MDS data. And they go in to say that specifically they're looking at the diagnosis of schizophrenia on the MDS for the residents in the long stay facility. There are instructions that come with the letter. There's a web portal and there's things that you have to do. Within 2 business days, you have to actually complete the form for access to the web portal because that's where you're going to upload information, right? And when I say within 2 days, it's within 2 days of that certified letter tracking date. So whatever date they said that arrived to our facility, we have 2 days to complete the portal access form and get that submitted. There's also a checklist, right? That for all the different information. There's detailed instructions on how we're going to then submit things via their secure web portal. After we do the document submission, then we're supposed to, or the submission form, then we're supposed to contact the CMS auditor that is listed. There is an actual CMS auditor listed on the form that we're then to contact to schedule the entrance conference, right? And they do also tell you that if we have electronic medical records, they are going to need access to those electronic medical records. So some of the other forms that come with this letter, there's a couple of attachments. Attachment A goes through the administrator, the MDS coordinator, the director of nursing, medical director, and the facility liaison, and you have to give a name, their position start date, their phone number, and their email address, because they're the people that the auditor will reach out to if they have questions while they're actually doing the audit. And then, you know, there's other information in there for our electronic health record. Again, if we have electronic health records, they ask how much of our record is electronic. Will we be, you know, all electronic, or will we have to submit portions of the requested information to that secure web portal? They ask other information such as what is our facility bed size and our current census. And do we use an in-house psychiatric provider? And has there been a recent change in providers? So all of that information are questions that have to be completed on attachment A. And then we have attachment B. And this is snipped right off of attachment B. And this goes into the supporting documentation checklist. So they give you a list of the different items that will be needed, right? They're looking for specific things. So they already know what residents they want. They have a list of residents that they're going to give you. And when they start asking for information, they're talking about specific MDS timeframes. So they're looking at the specific resident, and they're going to tell you that they want the MDS for that resident from admission, right? Because that's what they're looking for. They're looking for residents that were diagnosed with schizophrenia after admission. So they want that admission assessment, because that will be the one that shows that that diagnosis was not there. They then want the assessment that the first time schizophrenia was diagnosed, and then also the most recent MDS, because they want to see, are we still coding that? From there, they want the behavioral records. That includes all the practitioner records pertaining to that specific diagnosis. They're specifically looking for that medical evaluation around the time that the diagnosis was given. Right? That's what they're looking for, is that actual medical evaluation done by the practitioner. Then they're looking for our behavior monitoring, right? Do we have behavior monitoring, not only for the target behavior, but also for the side effects? And is that consistent? Do we have the behavior monitoring? And the other thing that they're looking for there is, what is that behavior, right? So as we had talked about a few slides back, what is the behavior? Is that behavior something that you see with schizophrenia, or is it something else, right? And then they want the medication administration records, because they want to see what are we treating, right? Are we treating this diagnosis with which classification? What is the dose? Have we done gradual dose reduction attempts? So if we have any of those things, they want that also. So that's all, kind of listed. They also list those things when you do your initial entrance conference. That's when they start talking about all of the different things that they want. Attachment C is your attestation form. This is where you're basically saying that, yes, I am going to provide all of the supporting documentation that you requested. And to my knowledge, this is accurate, right? Or we're going to say, I have personal knowledge that some facility supporting documentation referenced in B is not accurate. So this is where we're basically saying we want to forego the audit, right? We know that something was not done right. So there are two choices. This has to be completed. It has to be sent in. There's not an option to not sign it. You have to pick one of the two. And, then there's that attachment D, which is that web portal. In there, again, we have to complete the web portal request within 2 days. There's guidance then on how to access the web portal. And then there's guidance on what we're supposed to do with the form, how we're supposed to submit that. And they give you a specific email address that you're supposed to submit that web portal access form to. So as I said, once you do all those pieces, you have to schedule that conference call with the specific auditor that's listed on that letter that you received. And they're going to talk about, that they want read-only access. That read-only access has to be done relatively quickly. They give you that list of residents, and they go through the whole list of the items that they want. And again, they are telling you, this is everything that we want, right? It's the 3 MDS, the one on admission, the one where they are diagnosed, and the most recent one, the MARs, the behavior, all of those things. And they want that uploaded relatively quickly, right? So they want that uploaded. And I believe from what I've heard, it was like a 48-hour turnaround time, right? I was actually on a call with one of the buildings, and we talked to them on Wednesday, and they wanted the electronic access by Friday. And they wanted to know exactly when we were going to be able to give those documents. And it was pretty much like by early next week, was like pretty much the option. Can I have it by early next week? So these are all the things that we had just talked about, right? So the things that we want to look at are progress notes, right? From admission, from the time of that diagnosis, most recent ones, anything that talks about that schizophrenia. Do we have a medical evaluation? Have we done GDRs? What do our progress notes look like? We have to give them copies of our MARS and TARS and our behavior monitoring, right? And then that antipsychotic medication and the diagnosis. So any antipsychotics that we're using and the diagnosis related, right? That's all of the pieces that have to go to them to review so they can determine, are we in compliance? Again, this is something that they're looking at, not for every resident with that diagnosis, but for the ones that did not have it on admission and now do. Because, if you read the SOMA, if you look at all those, those pieces, everything goes back to, it's very rare that schizophrenia is diagnosed after the age of 40, right? It's very rare. So the problem comes into play when they didn't have it on that first MDS and now they do, right? Because it wasn't diagnosed obviously before the age of 40. And it's also very rare that you would have 17% of your residents that would be diagnosed after the age of 40. So they're the pieces that they're really looking at. So then we talk about the whole findings piece, right? So you will get a findings report, and then they will do an exit conference with you. So they'll do their exit first and say what their findings were, and whether they determined that that there is miscoding of I-6000, and then you'll get a letter. And that letter goes through a couple of different pieces, right? So for the diagnosis of I-6000, they can say that the diagnosis of schizophrenia was not noted anywhere in the medical record. However, it was listed on the electronic record diagnosis list and subsequently inaccurately coded on the MDS. So basically, there's no medical professional diagnoses or documentation for this diagnosis, but it's on our diagnosis list and we use it on the MDS. We shouldn't have done that because we didn't have the supporting documentation from the practitioner in that 60-day window. The diagnosis was present upon admission per the facility's submitted documents. However, the diagnosis was not coded on the admission MDS. That would be our error, right? It was there, but they may, not feel like we were misdiagnosing people or miscapturing diagnoses inappropriately. The last option there is the resident assessment instrument manual, so the RAI manual, was not followed regarding the requirements for the diagnosis to be coded on the MDS, including the progress note signed by the physician in the last 60 days and documentation of active treatment in the last 7 days. So they're the three pieces that they can say we found, that you didn't follow this piece, and that's why you had inaccurate coding. There's also an option for the diagnostic process. Review of the medical records lacked sufficient documentation of behaviors indicative of schizophrenia diagnosis for 6 months prior to the diagnosis. The review of the medical record did not contain documentation of a comprehensive medical or psychiatric evaluation completed by a physician that met the professional standards of practice at the time of the initial diagnosis of schizophrenia. So, that leads us to, all this guidance didn't come out until last summer. Some of it was in the regulations, but not as strict as it was as of last summer and then updated regulations. But this is going all the way back to whenever they were diagnosed. So even though they may have had a medical evaluation since then, if it wasn't there at the time of the diagnosis, they still can consider that we had inaccurate coding of the MDS. And that is one that I've seen happen. Even though when this guidance came out, the facility started auditing, they started contacting practitioners and saying, like, we need more. It was just too late. It needed to be there at the time that the medication was started. So then there's the psychiatric medication use, clinical indications, monitoring, and gradual dose reduction. So this is another piece of that findings letter. So they can say that the clinical indications for the use of the psychiatric medication were lacking in the medical record for the sample residents they looked at. Documentation of monitoring for adverse drug reactions was lacking in review of the medical record. The review of the medical record lacked documentation to indicate that the GDRs were recommended and attempted as appropriate. The sample residents were receiving antipsychotic medications. However, these medications were not appropriately coded on the MDS. Documentation of monitoring of target behaviors was lacking in the resident's medical record. And then it goes into the actions, right? So then it starts to talk about in that finding letter, again, what those actions will be. So it says, as a result of the audit, the facility's 5-star quality measure rating will be adjusted. So the overall quality measure long stay is going to be downgraded to that 1 star for 6 months, which will decrease your overall by a star. Short stay rating is going to be suppressed for 6 months. And then after that 6-month period, your long stay quality measure for the antipsychotics is going to be suppressed for that 12-month period. And they're going to continue to monitor, right? So some of the other pieces that I have in here, just as tools for you when you're looking and reviewing this, are the different regulations that are referenced. So F658, which is our comprehensive care plans that meet professional standards. This is where it talks about making sure that we have all of those pieces in place for that medical evaluation. F740, behavioral health services. We have F758, which is that free from unnecessary psychotropic medications. So all of those different regulations are the ones that, are really focused around this and had those updates I'm not going to read you all of this. This is just here as a resource when you're evaluating your systems. But this goes into what each one of those different regulations states. And, you know, the one that we want to focus on, and I do want to hit on a little bit here, is that F758, free from the unnecessary psychotropic medications. We have to remember that when we're talking about the psychotropics, they're looking at anything that can actually alter the brain activity. So we have our, you know, our antipsychotics, antidepressants, anxiolytics, hypnotics, but some of the new guidance also talks about those other medications that can alter the brain activity if we're using it to treat behaviors, right? So if we're using Depakote to treat a behavior and not because of seizures, then we still have to treat it like an antipsychotic medication or a psychotropic medication. So all of that information is in here right out of the REI manual. You know, the things that we have to think about with our, you know, our antipsychotic drugs. What is our indication for use? You know, that's going to be important for our people that are completing REI manual or the REI MDS piece for October, because that indication for use is going to be needed for all of those different drug classifications, right? And again, it has to be true, right, and real. So we can't say that we're using antipsychotic medication to treat dementia because that's not an indication. We can say that we're using insulin to treat diabetes, right? That's an indication for use. That medication was made for that diagnosis. So we have to think about that indication for use. Are we supposed to use this medication to treat this behavior? That evaluation piece, you know, we really have to think about what the evaluation has to look like. So when we talk about, you know, that detailed evaluation, that evaluation that has to be done by that practitioner, you know, there's a lot of different steps. So that is all listed out here for us, you know, and all the different pieces that have to happen for the evaluation and the monitoring, right? So that's where our gradual dose reductions come into play and our behavioral teams. And, you know, we should have our pharmacy involved with that. And we should have clear documentation that we attempted these, you know, gradual dose reductions, unless it was unsafe, right? Unless doing that gradual dose reduction put the resident at risk for causing harm to themselves or others. We really have to show, you know, that we are following the process for using the least restrictive medications on the residents. So all of that information is here, right? Key components of noncompliance. These are listed right in the critical element pathways, you know, and then there's also guidance for, you know, if the resident's on a, you know, one of those antipsychotic medications, you know, the surveyors are looking to determine were there other side effects that happened, right, that caused psychosocial harm, because now we're bringing the psychosocial piece into it. So because we put them on that medication, have they had a decline in their physical abilities, right? Are they having, you know, respiratory changes, bowel dysfunction, urinary changes? Have they had increased falls, headaches, you know, all of those different pieces? And they're looking at that now because we are using this medication also. And as I had stated at the beginning of the training, in the critical element pathway, again, it talks about, you know, do the practitioner's diagnostic practices meet professional standards? You know, and it goes into, again, that CMS is aware of situations where practitioners have potentially misdiagnosed residents with conditions for which the antipsychotics are approved use, which would then exclude the resident from the long-stay antipsychotic quality measure. So written very clearly exactly what they're looking at, right? They're looking to make sure that facilities are not giving residents diagnoses that will exclude them because they want true numbers, right? So we have to think about our documentation. Do we have that psych evaluation? Do we have our behavioral documentation and tracking? And not just for the targeted behavior, but for the side effects, right? Do we have the documentation for that whole diagnosis and when it occurred? Did they have the behaviors for that 6-month time frame? We have to think about our comprehensive care plan also, right? What are the targeted behaviors? What do we have in regards to interventions? Do we have the documentation for those gradual dose reductions? Do we have the documentation for the ongoing monitoring, the non-pharmacological interventions? No, and on this slide here, we have, you know, the schizophrenia diagnosis for the DSM-5, right? That DSM-5 diagnosis criteria for schizophrenia. It goes very clearly into talking about, you know, it's a serious mental illness, deeply affects people because of correct schizophrenia diagnosis can improve one's quality of life. It's important that they make the appropriate diagnosis. And it goes into all of that criteria. So I pulled that out for you. so that we can look at, what really has to happen there. So the first thing that you'll see is age, right? So inside the DSM, it talks about age. While it's not part of the diagnostic criteria, they do consider someone's age when they're diagnosing this, right? The typical age for schizophrenia diagnosis is between the late adolescence and mid 30s. It does vary, but it is abnormal that it is diagnosed in early childhood or late, like after the 40s, right? Same thing that is in that CMS letter. So it talks about the symptoms, right? So when the practitioners are diagnosing and when we inside our buildings are looking at these symptoms, we have to determine, do they have the appropriate symptoms, right? So they have to have 2 or more of the following, right? Delusions, hallucinations, disorganized speech, disorganized or catatonic behaviors, negative symptoms, right? So they have to have 2 or more of those. We have to have persistent behaviors for at least 6 months, right? So, those things have to be taken into consideration. So we have to think about the compliance steps then, right? What do we need? Well, we probably need to look at our policy and procedure for diagnosing schizophrenia, right? What do we have in place? Who can do that? Do we make sure that they're using the appropriate criteria with that DSM-5? Do we have the appropriate documentation for those behaviors, ongoing and persistent? No longer is it okay to start these antipsychotic medications because the resident had one bad day, one bad shift, or one bad weekend, right? We need ongoing persistent documentation. What do we have from that IDT team, and what are we looking at in regards to monitoring? What is the target behavior? What are the side effects? What does our MDS look like? Because if we don't have all those pieces, right? If we don't have that evaluation that meets the standards, then we still can't capture it on the MDS. So we have to develop an audit tool. That's the first thing every building should have done, right? An audit tool that says, this is the resident. Yes, schizophrenia is coded in I-6000. This is when the diagnosis was placed. Was it before or after admission? And then what is our treatment? If it was after admission, do we have that psychiatric evaluation? Do we have the documentation of those behaviors? Do we have the care plan, right? Do we have individualized interventions? So all of those pieces need to be on there because we're going to know relatively quickly if we have a problem, right? Are we diagnosing after they come in? One of the problems is a lot of times the residents come with these medications, and then we do send them to psych services that they've probably not seen before. And then they get the diagnosis. But we have to be very cautious in reaching back out and saying, is that true, right, and real? Not because we're questioning, that practitioner's, diagnosing, but we still are not probably going to be able to capture it because it happened after admission and we don't have all of those pieces. Now, if it's true, right, and real, we have the evaluation, the practitioner is 100% certain, yes, this is what it is. And we have those behaviors, we have all those pieces, then we can capture it. But right now, most of it, we don't really have all those things in place, right? So what's the diagnosis in I-6000? Because that's where it's going to be excluded. Are they on an antipsychotic medication? What's the supporting diagnosis? Do we have that comprehensive psych eval? Do we have persistent behaviors? Do we have a targeted behavior? Are we monitoring for not only that behavior, but the side effects? Is it correctly coded? That antipsychotic, is it correctly coded in MDS section N where we capture the med, right? Right now it's N410A. Is that correct, right? Does our care plan address the diagnosis, the behavior, and the interventions? And, what do we have in regards to those gradual dose reductions? So that is all of my pieces. I do have all the references listed out here, but I'm going to go ahead and turn it back over and see if there's any questions.
All right, thank you so much, Tammy. We already do have a question in there. I'm going to read a couple quick closing notes. At this time, if anybody else has questions for our Q&A, please submit them using either the chat or the Q&A tool in your Zoom menu. You can also raise your hand if you would like to request to ask your question out loud. I'd again like to invite everyone to next week's webinar, which will be about getting ready for the MDS 3.0 changes, and that will kick off a month-long series, and it will be next Wednesday at 2 p.m. at the same time, the same place. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright will be there to answer questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and our webinars in the newsletter we send out every Friday called the Last Minute Lowdown. If you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org and I will get you on that list. And I will drop my email in the chat shortly. And for anyone who missed my comment in the chat earlier, I will be emailing out these slides and the recording for this email later this week to the email that you used to register. So one of our questions that we have in here is, what about residents who are admitted with a prescription, or sorry, a diagnosis of schizophrenia?
So if they're admitted, this audit is specific to the resident being diagnosed after they were admitted. So that's why they're asking for the 3 MDSs. They're looking for the admission one, and they already know the answer to this. That's why they tell you the list of residents, right? They have all of this from all of our MDS submissions to the IKEY system, but they want that admission MDS to prove that it wasn't there on admission. They want the MDS, and they're going to give you the date of the one they want around when that diagnosis was added. And then they want the most recent one to see, are we still coding it? So this audit is specific to, were they diagnosed after admission? Still a good practice to look at everybody, because if we aren't medicating appropriately or we don't have all those pieces in place, we probably want them there anyway. But they're specifically looking at the residents after admission that were diagnosed.
Okay, thank you, Tammy. And I believe that's all the questions we have. Let me scroll back to the chat. Yes, that's all that we have so far. So I believe that's all we'll be getting for today. If anyone has a question, go ahead and raise your hand to save the time for typing, just so we know that you have one that you want to ask before we close. Okay, I think we can wrap up then. Before we sign off, I'd like to ask everyone here to please answer a short evaluation of today's webinar. The evaluation is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Tammy, thank you for joining us today and for this great and informative presentation. And I'd like to thank all of you for joining us today and hope you can join us again next week.
Thank you.